So, imagine your own immune system just slowly unzipping your skin right from the tissue beneath it.
Oh, wow. Yeah, that's a visceral image.
Right. And like there is no warning, there is no obvious external cause, like a burn or a cut.
Right, just a gradual, incredibly painful structural collapse.
Exactly. And it's happening entirely at a microscopic level. I mean, for years you might go to doctors and, be told it's just a persistent yeast infection,
Or they just brush it off completely. They tell you it's simply a normal part of going through menopause.
which is so frustrating.
It is the absolute definition of diagnostic muddy waters. It really is. Because when you are dealing with inflammatory conditions affecting the vulva and the vagina, I mean, the standard playbook goes right out the window.
Yeah, totally.
The skin in this region is constantly reacting to complex immune signals. So, reading those physical signs correctly is honestly one of the hardest challenges in modern medicine.
It really seems like it. And that is, well, that's exactly why we are here today. Welcome to the deep dive.
Thanks for having me. I'm excited to get into this.
Same here. We are taking a massive stack of medical guidelines, comparative dermatological studies, and clinical protocols. And we are zeroing in on a highly specific, frequently misunderstood medical mystery.
We really are.
We're going to decode the exact tissue changes that occur in vulval dermatoses, focusing heavily on this one condition called lichen planus.
Also known as LP.
Right, LP. And crucially, we are going to learn how to distinguish it from other incredibly similar conditions by reading distinct tissue markers.
Yes, particularly a marker called purpura.
Exactly, which is like the ultimate undeniable fingerprint for a related condition known as lichen sclerosus, or LS. So, okay, let's unpack this.
It's a really fascinating area to explore, primarily because the stakes are just so incredibly high for the patients.
Oh, absolutely. We're talking about real permanent changes, right?
Yeah, we are talking about irreversible anatomical changes if the signs are misinterpreted early on.
And that is why you, listening it right now, should care about this.
For sure.
Whether you are a medical student trying to memorize clinical presentations or a patient who has spent years navigating this like maze of dismissive misdiagnoses.
Or honestly, just someone who is insanely curious about how the human body's immune system can physically alter our tissues.
Right. I mean, this is basically a masterclass in reading the skin.
And reading it accurately means we can't just jump straight to the microscope. We have to, build an understanding from the outside in.
Meaning what we can actually see.
Exactly. We need to look at what the clinician or the patient actually sees with the naked eye before we even try to understand the cellular mechanics.
I completely agree. Let's set the visual landscape here.
Okay, let's do it.
We know lichen planus is an inflammatory condition, and it's widely believed to be autoimmune in nature. The body's T cells, which are, supposed to be our cellular bodyguards,
Right, the defenders.
yeah, they mistakenly turn around and attack the basal keratinocytes, like the foundational layer of our skin.
It's friendly fire.
But who is actually fighting this battle? I mean, earlier you mentioned it gets brushed off as menopause. It sounds like something that could easily be dismissed as a normal part of aging.
It gets dismissed all the time, largely because of the demographics involved. It's relatively uncommon.
How uncommon.
The clinical data estimates that about 1 in 4,000 women have vulvovaginal lichen planus.
Okay, so rare, but not impossibly rare.
Right. But the key statistic here is the mean age of onset for the vulval symptoms, which is roughly 57 years old.
Wow, right around menopause.
Precisely. The age of onset almost perfectly mimics the timeline of menopause.
Because naturally, dropping estrogen levels also cause vaginal dryness and irritation, right?
Exactly. It creates this perfect camouflage for the autoimmune condition to just progress unnoticed for years.
That is wild.
But when you finally look closely at the tissue itself, lichen planus doesn't just have one single look. It actually presents in 3 very distinct clinical groups.
Right. The 3 macroscopic faces of lichen planus. Let's walk through what those actually look like.
Sure.
The first one is the classical presentation. And from the sources, this shows up as these typical purple polyhedral papules.
Yeah, basically raised, multi-sided little bumps.
Right, and they're sitting right on the keratinized outer skin of the anogenital area.
And what's particularly notable about that classical presentation is the aftermath.
What happens after?
Well, when those little purple bumps eventually resolve and flatten out, they frequently leave behind areas of hyperpigmentation.
Oh, like dark spots.
Yes, especially in people with darker skin tones. The inflammation essentially disrupts the pigment cells in the area.
Makes sense.
But for some patients, this classical form can actually be completely asymptomatic. They might not even know it's there.
Which is definitely not the case for the second phase.
No, absolutely not.
That is the hypertrophic presentation. And honestly, this one sounds terrifying.
It is. It's relatively rare, thankfully, but it is notoriously difficult to diagnose.
Because instead of small bucks, the tissue radically changes into these thickened, warty plaques,
Yeah.
right?
It's the body overproducing keratin as a misguided defense mechanism against all that inflammation.
And these plaques heavily affect the perineum and the perianal area.
Correct.
And because they are so thick and irregular, they can ulcerate, they can get infected.
And they are intensely painful.
Right. But the scariest part for a patient, and I'd imagine for a doctor too, is that these warty, ulcerated plaques can painfully mimic malignancy.
Oh, absolutely. They literally look like skin cancer.
You'd see that and immediately think the worst.
The clinical anxiety there is massive, but interestingly, those hypertrophic plaques generally do not appear to involve the inner vagina itself.
Oh, really? They stay on the outside.
Mostly, yes. And that specific territory brings us to the third form, which is frankly the most destructive.
And the most common symptom-causing variation, right? Erosive lichen planus.
Yes, the erosive form. This one is intense.
Yeah, the mucosal surfaces are quite literally eroded away. It's just a raw, open area.
It is. But there is a defining visual feature, the specific fingerprint you are looking for right at the edges of these erosions.
Right, the tissue turns this glazed mauve or lilac color.
Yes. And resting right on top of that glazed border, you sometimes see this pale, delicate, lace-like network.
Wickham striae.
Exactly. Wickham striae is such a beautiful name for something so incredibly destructive.
It really makes me think of frost forming on a window pane in the dead of winter.
Oh, I like that analogy.
Yeah, like it looks so intricate and delicate, this lacy, white, branching pattern. But you only get that frost when the temperature outside is incredibly hostile.
Right.
So that lacy pattern is actually a sign of the harsh, destructive weather happening right below the surface within the immune system.
That's a very apt way to visualize it. That delicate frost is basically the visual footprint of an aggressive cellular demolition.
But wait, I have to push back here for a second.
Jen,
Let's clarify something for the listener. We are talking about a dermatological condition, right? A skin condition.
we are.
So why is a skin condition eroding mucosal tissue deep inside the body, like the vagina?
What's fascinating here is the structural distinction between different types of tissue,
Okay.
specifically keratinized skin versus non-keratinized mucosal surfaces.
What's the difference, practically?
Well, keratinized skin, like the outside of your arm or the outer labia, has a tough, thick, protective outer layer of dead cells.
Right, it's waterproof and tough.
Exactly. But mucosal surfaces, like the inside of your mouth or the vagina, they completely lack that tough barrier layer. They are non-keratinized.
Oh, I see.
So think about what happens when those autoimmune T cells attack the basal layer, the foundation.
Okay, so on the outside, the roof holds up even if the foundation is under attack.
Exactly. But in a mucosal surface, there is no tough roof holding it all together.
Wow.
When the foundation is attacked, the delicate surface layer simply sloughs off. It falls away entirely, creating a raw, intensely painful erosion.
So the local environment totally determines the type of destruction you see.
Yes, it does.
And from what I understand, that environmental preference is actually a massive diagnostic clue.
It is a huge clue.
If a patient comes in with internal vaginal erosions, the clinician can almost guarantee the diagnosis is lichen planus.
Because the primary look-alike condition, lichen sclerosis, typically spares the vagina entirely.
Wait, really? It just stops?
Precisely. Lichen sclerosis affects the outer keratinized areas, but it acts like there is an invisible stop sign right at the vaginal opening.
That is fascinating.
So if you see intervaginal erosions, you are confidently looking at lichen planus.
Okay, so we've mapped out the macroscopic landscape. We know what the frost on the window pane looks like.
Right.
But to really understand the mechanics of this destruction, we have to transition from what the eye can see to what the cells are doing.
We need to look under the microscope.
Exactly. We have to look at the histology.
Because the naked eye is incredibly useful, but it can be easily fooled, especially when the tissue has been inflamed or infected for months or even years.
Right. So a doctor takes a tiny punch biopsy, And crucially, they have to take it right across the edge of an erosion.
Yes, the edge is critical.
Because if you just biopsy the eroded center, there's no top layer of skin left to actually evaluate.
Exactly. You'd just be looking at raw tissue.
So when they put that edge under the microscope, lichen planus reveals a very specific, chaotic architectural breakdown.
It does. There's a lot of specialized terminology here.
Let's break it down for the listener then. The biopsy shows something called sawtooth acanthosis.
Acanthosis is just a thickening of the skin layer.
But here, the bottom edge becomes jagged, like it literally looks like the sharp, irregular teeth of a saw blade.
Right. You also see an increased granular layer and a dense, band-like infiltrate of lymphocytes.
Lymphocytes being the white blood cells, the immune cells.
Correct. They are just swarming the area in this thick, aggressive band.
But the most critical finding, the real engine of the disease, is something called basal cell liquefaction.
That is the critical mechanism.
Liquefaction.
Yes. The foundational base layer of the skin cells isn't just inflamed. It is quite literally being destroyed, liquefied, by those swarming lymphocytes.
The foundation is literally melting. But why is it melting? Like, how does a white blood cell actually liquefy a skin cell?
Through a process called apoptosis.
Which is?
It's essentially programmed cell death, driven directly by the immune system. The T cells are sending chemical signals that force the basal cells to self-destruct.
Wow.
If we connect this to the bigger picture, it shows how the body's highly tuned defense mechanisms can turn into localized friendly fire.
The body is entirely convinced that there is a hostile antigen, an enemy invader, hiding right in the basement membrane of the skin.
Yes, and the basement membrane is the anchor. It's the biological glue that holds the top layers of skin to the deeper connective tissues below.
Right. And the research backs up this enemy invader theory, doesn't it?
It does. Clinical data shows that weak circulating basement membrane zone antibodies are present in 61% of patients with erosive vulvar lichen planus.
That is just wild to think about. The immune system is specifically, relentlessly targeting its own anchor.
The body is effectively unzipping its own skin from the inside out.
Unzipping, yeah, that's exactly what it is.
And this brings us to one of the most vital parts of this entire diagnostic puzzle, the purpura contrast.
Right, because lichen planus, as aggressive as it is, isn't the only condition attacking this area.
Not at all.
We've mentioned lichen sclerosis, which causes similar white patches, intense itching, and severe pain. So how do we confidently tell them apart microscopically and visually?
It all comes down to purpura.
Yes, purpura is a crucial differentiator.
Yeah.
What exactly is it?
Purpura is essentially ecchymosis, which is the medical term for bruising beneath the skin.
Okay.
When you look at the tissue, you see these distinct purple or red spots where tiny blood vessels have leaked blood directly into the surrounding tissue.
And purpura isn't just a random symptom, right? The medical terminology used in the sources is critical here.
Right.
Purpura is pathognomonic of lichen sclerosis.
Pathognomonic is such a fantastic word.
It really is. It basically means a sign that is so uniquely characteristic of a specific disease that if you see it, the diagnosis is practically undeniable.
Yes. If you see purpura in this specific vulvar context, the sign points directly to lichen sclerosis, not lichen planus.
It's a definitive neon signpost.
Exactly. And to explain why it happens in early lichen sclerosis, the connective tissue beneath the skin loses its structural integrity.
Okay.
Because that tissue is weakened, the delicate little capillaries lose their support.
Oh, I see.
They become incredibly fragile and break at the slightest touch, causing that purpura bleeding.
Whereas lichen planus, with its cellular unzipping mechanism, simply doesn't damage the blood vessels in that exact same structural way.
Precisely. It's all about how the tissue fails.
And just to fully round out the contrast for anyone trying to build a complete mental map of this area, we should quickly mention two other conditions that frequently muddy the waters.
Good idea.
First, there's lichen simplex chronicus, or LSC.
Now, this isn't an autoimmune attack at all.
Right. It is essentially a localized itch-scratch cycle that has completely spiraled out of control.
Yes, LSC is driven by mechanical trauma. The tissue change there results in something called lichenification.
Lichenification.
Yeah. The skin becomes incredibly leathery, thickened, and often takes on an earthy color.
So there's no cellular liquefaction, no autoimmune unzipping.
No, none of that.
The skin is just desperately building a thick, leathery callus to defend itself from chronic, relentless scratching.
Exactly. And the final common lookalike is psoriasis.
Right.
When psoriasis occurs on the vulva, it presents as bright red, well-demarcated plaques. On the outer areas, you might see its classic silvery
And
scales.
if you look under the microscope,
Instead of a liquefied basal layer, you would see rapid skin cell turnover and Monroe microabscesses.
microabscesses.
Yeah, there are these tiny little pockets of neutrophils, another type of white blood cell, gather in the very top layer of the skin.
Okay, so if we take a step back, it feels like we have nice, clear categories, right?
On paper, sure.
We have sawtoothed liquefaction and unzipping for lichen planus. We have fragile blood vessels and pathognomonic purpura for lichen sclerosis.
Right?
We have leathery mechanical thickening for LSC. And we have bright red plaques with microabscesses for psoriasis.
It sounds so clean, so simple,
But here's where it gets really interesting.
because the human body refuses to be simple.
Never. The reality of clinical practice introduces a massive complication: overlap.
Oh, the overlap, yes.
Sometimes a patient has both lichen planus and lichen sclerosis at the exact same time.
It happens.
The tissue literally becomes a microscopic battleground hosting multiple, completely distinct immune wars simultaneously.
And this is exactly where clinical pathological correlation becomes a complete nightmare.
Let's define that. Clinicopathological correlation is the moment the doctor sits down, looks at the patient's physical symptoms, reads the lab's biopsy report, and tries to make the two puzzle pieces fit together.
Right, and because of this overlap and because of how much destruction happens, the clinical data reveals a staggering fact.
What's that?
Between 30 and 40% of biopsies in these cases can come back entirely inconclusive.
Wait, almost half?
Almost half.
That has to be so disheartening for a patient waiting for an answer. Why is the failure rate so incredibly high?
It highlights a humbling reality in pathology. I mean, we can identify the specific antibodies we know to look for the sawtooth ridges,
Right.
but when a patient's tissue has been chronically inflamed, scratched, bleeding, and eroded for 5 or 10 years, the primary microscopic evidence is often completely obliterated. The pathologist doesn't see a clean sawtooth pattern. They just see a chaotic, fiery mess of end-stage inflammation.
Wow. Which perfectly underscores why knowing the macroscopic markers like the intervaginal involvement for LP or the purpura for LS is so incredibly vital for the clinician who is actually sitting in the room with the patient.
Exactly.
Okay, so we've explored the microscopic destruction. We know how the immune system tears the building down. Now we have to look at the long-term aftermath. What happens when these eroded, unzipped, liquefied tissues try to heal themselves in the middle of a war zone?
Well, it's not good. When tissue that has been completely denuded of its protective mucosal layer tries to heal,
Yeah.
and it's doing so in a highly inflamed, tightly confined environment, it simply cannot heal normally. It scars.
And in the narrow confines of the vulvar and vaginal anatomy, that scarring leads to the formation of synechiae.
Right.
Synechiae being adhesions. The raw tissues literally fuse and glue themselves together.
Exactly. It results in a devastating loss of normal architecture.
The physical changes are profound from what I read. You see the complete resorption of the labia minora. The inner lips just flatten out and entirely disappear, absorbed into the surrounding scarred skin.
Yes, and the clitoris can become completely buried and trapped under shiny, thick scar tissue.
And internally, the patient can experience complete vaginal stenosis, where the vaginal canal dramatically narrows or even completely seals shut.
It's horrific.
Mm.
And the tissue that does remain is incredibly fragile. Patients develop friable telangiectasias.
Which are what exactly?
They have prominent, dilated, highly delicate blood vessels sitting right at the scarred surface.
Right, so even the slightest friction causes them to rupture and bleed.
Yes, this leads to a purulent or serosanguinous discharge, meaning it is persistently tinged with blood.
And it causes excruciating pain during intercourse, known clinically as dyspareunia.
Yes, dyspareunia. The physical, emotional, and psychological toll of this architectural scarring is just massive. It alters a person's fundamental relationship with their own body.
I can't even imagine. But what really shocked me is that this isn't just a localized, isolated genital issue, is it?
No, it is not. The immune system has a long memory, and it often has multiple identical targets.
We have to look at a phenomenon known as vulvovaginal gingival syndrome, or VVG.
Right.
This completely blew my mind. The exact same tissue changes, the same painful erosions, the same Lacey Wickham's dry frost often occur simultaneously across 3 entirely distinct sites in the body.
The vulva, the vagina, and the gums, or the inside of the mouth.
The clinical studies show that 50% of women who present with oral lichen planus will also have vulvovaginal involvement, half.
It demonstrates beautifully and terribly that the T cells aren't just confused in one local geographic area.
They are systemically programmed to seek out and destroy a very specific mucosal cellular profile.
Exactly, regardless of whether that tissue happens to be inside your mouth or inside your pelvis.
Which means a dentist or an oral surgeon might actually be the very first medical professional to spot the warning signs of a severe, life-altering gynecological condition.
It happens more often than you'd think.
That systemic interconnectedness is incredible.
It really is.
Now, regarding treatment, the medical guidelines are clear that while these tissue changes can be halted, the severe architectural scarring, the fusing of the tissues, cannot always be reversed.
No, once it's fused, it's often permanent without surgical intervention, which is risky.
So to stop the unzipping in the first place, the gold standard treatment is the use of super potent topical steroids, like clobetasol propionate.
You have to forcibly, aggressively quiet the local immune system to stop the T cells from liquefying that basal layer.
But I have a very practical question on behalf of the listener here.
Sure, go ahead.
If a patient is walking around with these raw, painful erosions, doesn't the sheer trauma of everyday life make it worse?
What do you mean?
I mean, simply walking, washing with a washcloth, wearing tight jeans, or having sex, doesn't that friction accelerate the tissue damage?
It absolutely does. And dermatology has a specific clinical term for this exact phenomenon. It's called the Koebner effect.
The Koebner effect.
Yes. It is a phenomenon where the physical trauma of scratching, or even just the mild repetitive friction from clothing, actually induces entirely new disease lesions to form.
In skin that was previously healthy.
Exactly.
Wow. So the mechanical stress essentially rings the dinner bell for the hyperactive immune system.
That's a great way to put it. It draws the destructive T cells to a brand new site.
This raises an important question about how we manage everyday comfort and hygiene for these patients.
It's exactly why the clinical management guidelines are so incredibly strict about avoiding any and all irritants.
No scented soaks, no tight clothing, absolutely no mechanical trauma.
Furthermore, they heavily recommend using bland emollients like simple white petroleum.
Not just to moisturize the skin, though.
Right.
Yeah.
It's to create an artificial physical barrier over the compromised tissue. You are trying to protect the raw nerve endings and shield the skin from the friction that triggers the Koebner effect.
You literally have to artificially replace the protective roof that the immune system liquefied.
Precisely. You have to be the barrier.
So what does this all mean if we step back and look at the entire landscape we've covered today?
It's a lot to take in.
It is. The tissue changes in lichen planus are truly a masterclass in immune misdirection.
They are.
We started with the visible frost on the window pane, the delicate but destructive Wickham striae.
And we zoomed all the way into the microscopic sawtooth borders, where the skin's foundation is literally melting and unzipping.
We learned how starkly different this underlying mechanism is from the leathery, callus-like skin of lichen simplex caused by scratching.
Or the highly fragile blood vessels that cause the pathognomonic purpura of lichen sclerosis.
And most importantly, we saw how, without swift intervention, this invisible microscopic warfare leads to irreversible macroscopic devastation.
The fusion of tissues and the tragic loss of normal anatomy.
Right. And for you listening, whether you are a clinician trying to solve a puzzle or a patient advocating for your own health, this knowledge is power.
Absolutely.
Being deeply informed about the specific markers of tissue change, knowing the critical difference between purpura and an erosion, knowing that oral symptoms in your mouth might connect directly to pelvic symptoms, empowers you to demand precise biopsies and early aggressive interventions.
It is the crucial difference between noticing the frost on the window early enough to turn up the heat versus letting the entire house slowly collapse from structural damage.
Accurate, informed observation is always the first and most critical step in effective treatment.
I couldn't agree more.
Which brings us to a final lingering thought to wrap up today's deep dive. We've talked extensively about how our skin, our largest and most visible organ, can manifest these highly specific, deeply destructive immune wars across entirely different mucosal borders simultaneously.
Like the mouth and the vagina.
Exactly. If the human immune system is capable of memorizing a cellular target so precisely and attacking it at opposite ends of the body at the exact same time, well, it really makes you wonder,
Wonder what?
what other silent systemic immune conversations are happening deep inside our bodies, in our internal organs, in our joints, or in our nervous system, just waiting for us to figure out how to read the physical signs.
That is a fascinating thought.
Think of your own body not just as a collection of isolated parts, but as a vast, interconnected map of immune memory. The signs are always there. We just have to learn how to read them.